Good morning and welcome to the second session of Health Matters this morning. I hope you all enjoyed your first session. I'm Margaret Raffin, and as a member of the hospital board, it's my pleasure to welcome you all and thank you for being here to learn more about Stanford as not only a place to come when you're sick, but also as a community resource to keep us all healthy. Today, I have the great pleasure of introducing two very talented people here at Stanford who are going to talk to us about the diagnosis and management of cancer. Dr. James Brooks holds the Keith and Jan Hurlbut Professorship in Medicine and is the Chief of Urologic Oncology in the Stanford Department of Urology. His research focuses primarily on the diagnosis and treatment of early-stage prostate cancer. In 2013, Dr. Brooks was named to the highly selective prostate cancer research program integration panel, joining America's most innovative leaders in prostate cancer research. Joining Dr. Brooks today is Dr. Max Diehn. Dr. Diehn is a Stanford radiation oncologist and pioneer in cancer screening. He has developed a new blood test for early cancer detection. In 2013, he was awarded the National Institute of Health Director's New Innovator Award and is continuing his research on cancer genomics. So as you can see, these are two very, very well-respected and innovative leaders, and please join me in welcoming both Dr. Brooks and Dr. Diehn.
Thank you, Margaret. It's a delight to be here. We're going to talk about cancer screening generally, but use our particular foci as examples of what can be done in cancer screening and what some of the pitfalls and problems are in cancer screening. The concept behind cancer screening and detection, early screening and detection, is simple. You find the cancers early while they're small and they're confined to their organ of origin, and then treat them focally. Either remove them, treat them with radiation therapy, and so on. And do so before the cancer spread. Obviously, the reason for that is because once cancer spread, particularly cancers of solid organs, they are very, very difficult to treat and often lethal. Now cancer screening, we understand broadly, we all have our screening, colonoscopy and PSA testing, breast cancer screening, and even lung cancer screening recently with spiral CT of the chest. So we understand this concept. It's a part of our medical care. And if we take prostate cancer as an example, it looks like screening in many ways has been successful. I'll give you an example. If you look at 1990, the men who walked into my office with prostate cancer, just about, if they had a diagnosis of prostate cancer, about 1 in 5 had cancer that had spread outside the prostate gland to other sites, lymph nodes, bone, and so on and so forth. That number, since screening has started recently, is 1 in 25. So it looks like it reduces the number of men with metastatic disease. Second, if you look, prostate cancer death rates were slowly rising over the past century. And remember, PSA testing started in the late 1980s. PSA testing started in the late 1980s. Prostate cancer death rates peaked at about 42,000 or so in 1992 to 1995. In the last couple of years, they've been somewhere around 28,000. So actually, about 15,000 less men per year are dying of prostate cancer, and most of us ascribe that to early detection and early treatment of prostate cancer. So while it looks like screening and detection is valuable, is saving lives, it's being heralded by the National Cancer Institute and the American Cancer Society as saving people's lives, big success story in prostate cancer, suddenly come headlines like this. That suggests that PSA testing, PSA is prostate-specific antigen, it's a protein measurable in the blood, is no longer useful. It doesn't save lives, it leads to unnecessary treatments and side effects. And this has led several societies to start to recommend against PSA testing. And in fact, yesterday I just saw that I just learned that the AARP is recommending against prostate cancer testing, which makes me sad, not only for the policy reason, but also because I'm on the mailing list for AARP. So how did we get here? What does this mean? Well, I think that these studies, these recent studies, are the result, we're almost a victim of our own success. They're the results of two features. The first feature is that PSA, prostate-specific antigen, is not prostate cancer-specific antigen. It's a protein found in the blood that can be elevated by anything in the prostate, and the product of that is it does lead to a lot of unnecessary biopsies and so on. The second is something we've known about for many, many years, and that is there are many men walking around who have cells that a card-carrying pathologist would call cancer that will never die of their cancer. So there are men who, on autopsy, if you look in their prostate, you can find cancers, and that increases with age, such that if you look at a man in his 50s, almost a third of them have cells in their prostates that people would call prostate cancer. Men in their 60s, it's almost half. By age 80, it's about 80%. Okay, so there are many men walking around with prostate cancer, yet only 2.8% of men will die of prostate cancer ultimately in their lifetime. Okay, so a small fraction die, but many men have it. And this leads to problems. And I think, let me just give you an idea of why I think we've run into this particular problem with screening, that is, people starting to recommend against it. If you look in 1990, this is just an example of a population of people in the United States. There are a small fraction of people who have aggressive prostate cancer. That's these little guys with in red up top. These are the autopsy prostate cancers. These are the men with no prostate cancer. When you start screening, the first time you do a PSA test, you're going to find a lot of the big bad cancers. So you notice a lot of the guys at the top disappear, but you also dip into the autopsy prostate cancers. The problem is we've screened over and over and over again. We recommended yearly PSA tests. So each time we screen, we find proportionately more men with autopsy prostate cancer and proportionally fewer men who have the aggressive forms of prostate cancer. And the product of that is that your screening test is not going to save lives, right? If you're picking out people who aren't going to die of the disease, you're not going to save lives. And the product of that is a problem. As I mentioned, while death rates are falling, many men get unnecessary biopsies. Their PSA is elevated for other reasons. But more importantly, and the issue that's very acute right now, is that many men we're finding a prostate cancer don't need to have it treated. They don't have life-threatening disease. And yet, in the face of uncertainty, they get treated because we don't know which ones are the so-called tigers and which ones are the so-called pussycats. We have no real good ways of telling them apart. Now, we have some clinical parameters, and we can talk about those, that give us some clues which ones are aggressive and which are non-aggressive, but we're still not perfect, and there's all kinds of vagaries surrounding that. So the product is that the bias is towards treatment, and in fact, even though we are increasingly advocating for active surveillance, that is watching certain men with cancer and not treating them, if you look at the rates of active surveillance use between 1990 and 2005, when they should have really increased, we should be watching more and more men, the rates remain flatlined at about 9%. Okay, so we are not using more surveillance, which we should be doing. So this has kind of fueled mine and many of our research programs as to how to overcome this problem. And there are two problems, as I mentioned. The first is a more cancer-specific test. The second problem is picking out which ones are the aggressive ones and which are the non-aggressive ones. About 10 years ago, a group of us published research looking at gene expression in prostate cancer. And this is an example from that paper, and this is what's called a heat map. But basically what this is each column, if you will, represents an individual patient sample, and each row represents an individual gene. So pink is normal prostate, blue is prostate cancer. And what we described and what we found back then was a variety of gene expression changes in cancer compared to normal. And these are ones we thought might be good tests that are cancer-specific tests. That is, genes that are turned on in prostate cancer and not turned on in normal prostate. And this is a set of genes, the red ones here. Red means the genes are turned on. Green means the genes that are turned off. So we thought those would be good markers for prostate cancer. The problem is what we were measuring was RNA. This is genes that get turned on. So what happens, you have DNA that's stretched out, and along the stretches of DNA are individual genes. They make about 2% of our total genome is actually coding genes. When a gene gets turned on, you Xerox multiple copies of that into what's called RNA. RNA is the script, more or less, that tells the cell how to make a protein. Now, protein is the workhorse for much of what goes on in our body. Our skin is mainly protein, for instance, all organs are, and so on. The problem is this: DNA, chemically pretty stable. Protein, chemically pretty stable. Both can be measured pretty well. RNA is very ephemeral. It's very hard to keep it stabilized. So using RNA as a marker, there are some tests that are out there, and I can talk about those later, but it's not good to use for a clinical test. That's the first problem. Second problem is, well, okay, let's look at the proteins that are made in response, that are encoded by these RNAs. Turns out most of those failed for a variety of reasons as cancer-specific tests. And I can talk about that in the discussion session, why that might be. So that's led us to think more about DNA. Now, it turns out DNA has got some interesting properties, and Max is going to talk about some of his work looking at DNA as a cancer biomarker. I'm going to touch on some of our work on it as a cancer biomarker. It turns out DNA can be chemically modified. It can be modified by adding methyl groups. So that's what the little red circle is to DNA. And that tends to turn genes off. What's nice is that there are tools that we can use to measure methylated DNA. Now, about 20 years ago, a group of us described a chunk of DNA, a gene that was turned off by methylation called GSD-Pi in prostate cancer. It happens very commonly in prostate cancer, and that is actually incorporated into some new tests that are coming out in the market now. The problem is that not everyone's cancer has that. For instance, Tom's might have it, but Bob's doesn't, right? Doesn't have that methylation change. So that's led many of us to think, maybe if we look at a panel of genes, look at many genes, that way averaging over a large group of people, at least one or a couple of them are going to have the methylation changes. So we've looked at methylation broadly. This is about 100 different genes we found methylated in prostate cancer compared to normal. This is red is the bad stuff here. We are now in the process of developing urinary tests in which you can actually measure methylated DNA sequences in the urine that occur uniquely in prostate cancer. And we're pushing along to develop this as a clinical tool for diagnosis. So this is starting to address problem number one, is a more specific cancer test. So rather than having an elevated PSA and getting a random biopsy of your prostate, we're honing in more on the men who actually are at risk for prostate cancer. But that doesn't solve all problems. So while we have several biomarkers, I mentioned GSD-Pi as one. Now we have several other methylation marks, but there are several other markers that are out there. It doesn't solve problem number two, which is, so what if we have a good test that finds cancer, if we find a whole bunch of autopsy cancers, right? So we need to figure out aggressive versus non-aggressive prostate cancer. So we've spent a lot of time doing that. I'm only going to touch in one research area that we've been working on, but there are many projects we've had working on this. And that is looking at, again, gene expression. We've published over the years a number of papers, and this is one recent paper that we published identifying this gene, NuSAP, as a marker of aggressive prostate cancer. This is now incorporated into a couple clinical tests that are being sold out there. One of them is called Prolaris. It's also another test called Decipher. By way of disclosure, I didn't patent anything. I just published those, so they're all using those freely. And these markers are now being used to look at biopsy samples to tell which have the genetic signatures of aggressive disease versus non-aggressive disease. So this is a field that's moving along. Now, let's say we come up with a set of markers that help us predict aggressive versus non-aggressive disease. The problem we've had is that we have been using surgical samples to develop these markers of aggressiveness. What's the problem with that? The problem is the patient's already been treated, right? They've already had their prostate taken out. And what I would like to come up with is signatures or a set of markers that allows me to find which ones are aggressive so I can not take the prostate out, right? That would be the good thing. The problem is who has samples like that, right? We thought about this a few years ago, and a group of us got together and set up a study called the Active Surveillance Study, Prostate Cancer Active Surveillance Study, or PASS. This was funded by the Canary Foundation, which is a local group that's very interested in early detection of cancer. And in PASS, we've enrolled now over 1,000 men in active surveillance in which we are collecting blood samples, urine samples, biopsy samples, and putting them in the bank with the idea that when we come up with the perfect test, or at least a pretty good test that tells us aggressive versus non-aggressive disease, we'll have a sample set. Plus, these patients we're following along, some of them go on and get treated because even though using our crude clinical parameters now, we pick some of them out as having non-aggressive disease, but it turns out they had more aggressive disease than we thought. Some of them get treated. So now we can compare at the time they walked in the door with their diagnosis of prostate cancer, if they got treatment because they had aggressive disease versus continuing on active surveillance, we can compare up front. Did they have these genetic markers of aggressive disease or not? And that way, hopefully, change care, right? Change the way we stratify men for high risk versus low risk prostate cancer. So that's what we're working on right now. And this study is moving along. Like I said, we have over 1,000 patients now, so we should have enough samples that we can answer these questions. So what I'm hoping for in prostate cancer is that we move from the current practice, which is patient has elevated PSA, they get a blind biopsy of their prostate. It's the only cancer we diagnose by randomly putting needles in an organ, blind biopsy, and go on and all get treated, to a more complex means of managing patients that's much better for patients. A multiplex assay, looking at many markers to detect the cancer. We now are doing image-guided biopsies, and I can talk about that in the question and answer session, to better target where the cancers are in the prostate. And since we find the cancer, we can better predict how it's going to behave. Predict, is it aggressive or not aggressive? If it's not aggressive, they get active surveillance. If they are aggressive, eventually we want to go to tailored therapies. But for now, even if they just come to Max and I for radiation or surgery, we're only doing it on the subset that really needs the treatment. And with that, hopefully we better manage patients with prostate cancer. Now at this point, I'm going to stop and let Max tell you about another DNA-based test that he has invented to look at cancer to develop as a tool for cancer screening broadly. And this is something we're enthusiastic about. He and I are going to put a grant in probably in the next few months to do this in prostate cancer, for instance. So Max, I'll let you take over.
Great. Thanks so much, Jim. Wonderful to see so much interest in what we do here at Stanford, both as far as improving health directly and also research for future improvements. So thank you all for coming. As Jim mentioned, I'm going to be talking about a new screening approach that we've developed that we think is very exciting for a number of reasons, not the least being that it is potentially applicable to nearly any kind of cancer. And so, as Jim mentioned, we're going to apply this to prostate cancer, but what I'll tell you about today is its initial development for lung cancer, which is what I specialize in treating. So Jim has already introduced this concept, the broad area of cancer biomarkers. A biomarker is basically a substance in the body or a process that could tell a physician that there is cancer in that patient's body. So ideally, such a biomarker would be non-invasive, like a blood test or an imaging test, because you'd like to be able to do it in a way that doesn't hurt and doesn't cause discomfort, and that you could do repeatedly and not put the patient at risk. The best kind of biomarker could be used for a number of different things. So first, it might be able to predict how long a patient will live at the start of treatment. It may also be able to tell the physician what is the best treatment for that patient, maybe no treatment, maybe which exact drug to use, or whether surgery or radiation, for example. you might be able to use it to detect cancer that's left over after treatment. So to really try to identify which cancer survivors are really cured and which ones may still have cancer in their bodies. And then ultimately, and of course the big focus of our research and of this session is, could it be used to detect cancer in the first place? So cancer screening or early detection. We've been working in this as cancer researchers for many decades, and unfortunately have not made nearly as much progress as we had hoped. Really, in the last 30 years, there have been no new significant circulating biomarkers that have entered the clinic, particularly for early detection. And really, in a lot of ways, PSA is the poster child of the best example we have, and as you have heard, that it's far from a perfect test. So why is that? Well, there's a number of different problems that scientists have had to deal with. The first is the biology. As Jim mentioned, most of the biomarkers we've looked at so far aren't really specific to the cancer. They're expressed in the cancer as well as in normal tissues. So that already makes it much more difficult to use that to only tell you that there's cancer present. There are many, many technical challenges. So how do you detect these biomarkers? What molecular assays do we use that are really difficult problems from an engineering and a scientific standpoint? And then many of the biomarkers that we have discovered, unfortunately, have weak predictive power. They may tell us that there is cancer there, but not very accurately. So sometimes they're right, sometimes they're wrong. They're better than chance, but not much better than chance. And if you have such a biomarker, that will not be useful in the clinic. So like PSA, most biomarkers that have been studied are protein-based biomarkers. These are the protein products of genes that are made by the cells. And they are nice because they're usually made in high abundance. So there's a lot of it in each cell, and that makes it easier to detect. The big problem is that the proteins are also expressed in normal cells. And so one of the motivations for our work is we wondered whether, let's take a step back, let's try to think outside the box. Are there other things we can look at besides proteins that could be useful biomarkers? And the area that we are focusing on is something known as circulating tumor DNA. What that refers to is DNA, which is, of course, our genetic material, that all of our cells have DNA in them. It's the chromosomes. But circulating tumor DNA is little pieces of the cancer cell's DNA that we can find in the blood. And the way it gets there is that in patients who have tumors, even if they're not being treated, there's always some cells within the tumor dying. Tumors divide very rapidly. They divide too fast for their blood supply, and then some cells will always die. And some of the cells, when they die, they pop open, and their DNA, which are these little helix molecules here, get into the blood. And so then when you take a blood draw from a cancer patient, you can get access to these little pieces of DNA from the cancer. Now, in the circulation, there is not just cancer DNA. We all have DNA in our blood. For those of us who don't have cancer, that DNA is all from our normal cells, because we always have normal cells every day in our bodies that are dying and getting cleared out, and they contribute a DNA to the blood. But in the cancer patient, a little bit of this DNA is from the cancer, and the way we can find that is by looking for the mutations that are only found in the cancer. So as I'm sure many of you know, in the end, the key problem in cancer is that there's mutations in the genetic material of the cancer cells, and those mutations let the cells divide forever. And so those mutations are a problem, but they can serve as very nice markers because only the cancer cells will have those mutations. And if we can find those mutations in these little DNA molecules, then we can say, this must be coming from the cancer. We've known about circulating DNA and circulating tumor DNA for several decades, but it hasn't made it to the clinic either. And so why is that? Well, there have been two main biologic challenges. The first is that there just isn't very much of the DNA, even in healthy individuals. In 2 milliliters of blood, there's only about the equivalent of 5,000 cells worth of DNA. That's a very small amount, and it's very challenging then to work with because anything you do to that material risks losing it. The second is, as I already mentioned, is that the fraction of this circulating DNA that's from the cancer is very small. So you start with a small amount, and a tiny fraction of that is an even tinier amount. So that hasn't deterred prior investigators to study this, and there have been some assays developed, but none of them have made it to the clinic. And this, I think it's for two main reasons. The first is that the majority of those assays are not sensitive enough to detect these tiny amounts of DNA. So when you apply them to cancer patients' blood, in most cancer patients, you don't see anything. And the second is that there are a few tests that are quite sensitive, but they are very focused on a very particular mutation that only a very tiny fraction of cancers have. So they work very well for the patient, the 1 in 1,000 patient or 1 in 100 patient that has that particular mutation, but they don't work for the other 99% of patients, and then therefore they're not really clinically useful. So we developed at Stanford here a new method, and this is done in my lab with close collaboration with a colleague of mine, Asher Lizadeh, who's also a professor at Stanford. we developed a new method called cancer personalized profiling by deep sequencing, or I'll refer to as CAP-seq. And I won't go into the nitty-gritty technical details because that's not important, but I'll just describe big picture how this works. And so what we first do is we decide what parts of the genome are important in the cancer that we care about. And for this talk, it'll be lung cancer. The lung cancers have mutations, but not in every part of the genome. They're often repeatedly occur in certain parts of the genome. And what we then do is we use computer algorithms to identify what fraction of the genome is most often mutated in lung cancer. And this is a very tiny fraction, 0.0006% of the genome that we end up focusing on. The reason we focus on this small part of the genome is because that makes it economically feasible. You can't look at the entire genome, it's much too expensive. So we identify for each cancer the relevant part of the genome that we care about, where the cancers most often have their mutations. So this would look different for prostate cancer than lung cancer than breast cancer. And so these are our target regions, and that's what we want to then sequence. And by sequence, I mean we want to identify whether there's a mutation there or not. And then to actually apply it to a patient, what we do is we start with getting a little piece of the patient's tumor. So here at lung cancer, we get the cancer DNA out, we sequence it with our CAP-seq technology, and we discover the mutation signature that that patient has. Every patient will have a different signature, different set of mutations. No two tumors will be alike. And then when we identify that signature, we can use the exact same technology, apply it now to the plasma DNA or the cell-free DNA from the blood, and we can look for those mutations that we know the cancer has. And if we can do this, then we can say, oh, 10% of the DNA in the blood, 1%, 0.1%, whatever it is, comes from the cancer. So this lets us get a very quantitative measure of the presence of cancer. And importantly, and this is very key because it's very different than the protein-based biomarker, is that using CAP-seq, we can create a personalized biomarker for every patient. Every patient's biomarker is different, even though the tool we use is the same in every patient. Because what makes it different is that the signature of mutations that that cancer has are unique to the patient. And that's very important because it gets over one of the main hurdles of protein biomarkers, which is it adds specificity. The mutant DNA is specific to that patient's, and specific to that patient's cancer cells. It's not coming from any other cells in that patient's body. So, as I mentioned, we initially developed this for non-small cell lung cancer. That's the most common type of lung cancer. And we looked at over 40 plasma samples in both cancer patients and normal controls. And first we asked, how often can we detect DNA in the blood in cancer patients? And what we found was very exciting is that in every patient with stage 2 and above disease, so stage 2 is a large tumor that's in the lung but hasn't spread anywhere. In every patient with stage 2 and above disease, we can detect the DNA before treatment. So that's revolutionary for lung cancer. Lung cancer has no PSA, it has no biomarker, there's nothing like it. Even more exciting, we looked at stage 1 tumors, which are the very tiny tumors, and ideally we would discover by screening tumors at stage 1. We were able to detect it in half of patients. We've actually now done more experiments since our initial, and now we're up to about 65% of patients in stage 1 that we can detect this in the blood. So that suggests that we can potentially use this technology to detect very small cancers. So in the remaining time, I want to give you a couple of examples of how one could use this kind of approach in the clinic and how we think this could help patients ultimately. And there'll be a couple of applications, a couple focused on patients who are known to have cancer, and then at the end I'll talk about using it for screening for patients who are not known to have cancer. So the first is measuring treatment response. Those of you who have a family history with cancer will know that one of the very frustrating and difficult things about cancer treatment is seeing whether the treatment worked. Usually we do that through scanning. The problem with scanning is that it is very subjective, that interpretation. Did the tumor shrink? Did it not shrink? If two doctors look at the same scan, they can come up with different answers, because often these shrinkages are not massive, they're subtle, and so you can get very different answers. So one doctor will tell you, oh, you had a great response, and then we'll say, well, it's not really working, and that's important because that may determine whether you should change therapy. Also, treatment like surgery and radiation cause scarring, and scarring on a scan can often look like cancer. So the treatments we use to try to cure cancer cause changes on the scans that look like cancer. You can see how that can become very tricky as far as how to tell a patient whether they're cured or not. And then lastly, and very importantly, the scans are not very sensitive. They are, you need billions of cells in one spot to be able to see a cancer in the body. So of course, if there's millions of cells in a couple different spots, then the scan will not find that. So we need better tests, and that's why so much effort has been placed on biomarkers. So could CAP-seq be used to offer a more sensitive and unbiased, because now we're not looking at a picture, we're actually getting a number out from the computer. So here's an example of how it could be applied. So for these graphs I'll show, there's always some pictures here, which is the scans that patient had at different times. So this is at the beginning of diagnosis and then different months over treatment. And then down here on the graphs, there'll be these blue triangles and lines. The blue is the tumor volume as we measured on the scan. So we look at the scan, we say, oh, there's this much, many milliliters of tumor present in that patient's body. And the red will be the measurement with our CAP-seq technology of the circulating DNA in the blood. And what I want to show with this graph is that, so this patient is a metastatic lung cancer patient. He started with getting chemotherapy. The tumor shrunk a little bit. That's shown here in the blue. And at the same time, the blood DNA went down. Unfortunately, the patient then became resistant to chemotherapy. The tumor grew, and at the same time, the DNA went up. The next switch to chemotherapy really didn't do anything. The tumor didn't change in volume. This didn't really change very much. But then finally, the patient goes on one of the newest cancer drugs we have, a tyrosine kinase inhibitor that's specific to this patient's mutations, and the tumor basically shrinks to nothing, and the circulating DNA goes down. So this shows that you can use this blood-based measurement and that it very nicely recapitulates what the scans show. So maybe in the future, we don't have to do so many scans, which are expensive and give patients radiation. Maybe we could just track this through the blood and then only do scans when we see things are progressing. Here's another problem that I very commonly face in my clinic, which is that the treatment-induced tissue changes. So here's a large tumor, lung cancer, that was treated with radiation only. 4 months later, we repeat the scan, and you have this big abnormality still. The radiologist looks at this and says, well, the treatment didn't really do much. So, actually was by the criteria we used was considered stable disease. However, now fast forward, the patient is now out over 2 years, and this has just turned into a scar. And the patient has not developed any new cancers, and as far as we can tell right now, she's cancer-free. So when we went back in retrospect and looked at this time point where the scan still showed lots of tumor volume, there was no detectable circulating tumor DNA. Suggesting this kind of blood test might do better than a scan in these cases, where we can more accurately say, well, there really isn't much or any cancer left in the body. And then here's a similar example. This is a patient who got very high-dose radiation to the lung tumor. This is what I specialize in clinically. We can cure lung cancers greater than 90–95% of the time with that approach, early-stage lung cancers. But the problem is, at 4 months after treatment, we always see this. There's still this big abnormality that still lights up on our scans. And that's because the radiation causes inflammation, and the inflammation looks the same as cancer. But again, when we looked at the blood marker, it was gone at this time point, and then now the patient's out almost 2 years. This is just a scar, no evidence of cancer, no DNA in the blood. And then lastly, this is the same thing with a surgical patient. The tumor's here, gets cut out. We can detect the DNA before surgery, and now it's gone after the patient's about 3 years out, has no cancer left by scan and no by DNA, and hopefully is cured. How about detecting residual disease after treatment? One big problem is that after treatment, everyone gets the same kind of treatment. We try to cure the patient, but then we have to do this following with scans to see if the cancer comes back. Could we use CAP-seq to look at that problem? And here's an example of that. This patient had disease in the lymph nodes as well as in the lung, got chemoradiation, and at 5 months, the lymph nodes are now a normal size, so no evidence of disease. We were excited about that. Unfortunately, 7 months later, the patient developed spread of the cancer into the liver and in the brain, and then died a month after that. When we went back and looked at this, this time point where the scan basically showed no more tumor volume, the DNA actually had gone up a little bit, suggesting that there was microscopic disease elsewhere in the body, likely in the liver and the brain, that the blood DNA could pick up, but that we couldn't see on the scan. And so then lastly, what about screening? Imagine in the future being able to go to the doctor, get a blood test like for a PSA, but now instead of screening for one cancer, what if we could screen for many cancers by looking at mutant DNA? If there's mutant DNA in the blood, then it would lead the doctor to maybe get a scan, and maybe the exact kind of mutations in the blood could even tell the doctor what kind of scan to order. Should one look at the prostate? Should one look at the brain, the lungs? That would be revolutionary if we could do that. So is it possible to do that with a circulating DNA approach? And so the short answer is not yet, but we're very hopeful that it may be possible someday. And so we try to do such an experiment by taking patients where we knew that they had cancer, and we ignored that we knew about their mutations in the cancer, so we just looked at their blood sample, and we asked, can we find in the blood sample alone evidence of mutant DNA before knowing what mutations to look for? And that's what these gold circles are. This is finding mutant DNA in the blood without knowing before that they're there. And what we found was that in all patients with stage 2 and above so far, we're able to detect the DNA in the blood without knowing what the DNA mutations were. But in controls, healthy individuals, we don't find any of these mutations. So this is very encouraging. The reason it's not ready even for prime time is that the limit of detection right now is 0.4% of circulating DNA, and we really need this to be at 0.01% for it to work for early stage cancer. But this is a major focus of research in my laboratory now is can we make this assay even better? And we have some ideas on how to do that, we think, so that maybe we can get this to be used for early stage detection. So in conclusion then, I think circulating tumor DNA represents a really exciting and promising new biomarker that really could complement or replace the protein biomarkers that we've been using. Importantly, it creates a personalized biomarker, and that really facilitates personalized medicine. And I didn't show it here, but we can really apply it to many cancers, and we've already started doing that. And every cancer has mutations, so as long as one knows what the mutations are, one can use this kind of approach. And I hope I showed you that there's potential very exciting applications of this. So that's the end of my talk, and I think that will open the question and answer session for both of us.
Our first question is from Twitter. Holly Erickson asks, when will they update the Gale assessment model to include breast density for more accurate breast cancer screening?
Neither of us do breast cancer.
Neither of us do breast cancer. So we do, yes.
I don't know. I'm sorry. Maybe you know, I don't.
I don't know off the top of my head. Of course, breast density is a major issue in screening for breast cancer by mammography because it can hide tumors. But yeah, I don't work in that area, so I couldn't give an accurate answer to that.
I was just wondering, how much information does your circulating DNA hold? Can it tell you the drug sensitivities towards the tumor?
Excellent question. So that is one exciting application I didn't mention. If we know, in a lot of cancers now, particularly in lung cancer, for example, we know that certain mutations make the patient sensitive to certain drugs. And absolutely right, because we can see the cancer DNA there, you can imagine taking a blood draw rather than having to do a surgery to get at the tumor and ask, which of the sensitizing mutations does that lung cancer have, and thereby pick the drug. And that's absolutely a potential application, and I think that may actually be one of the first applications of this clinically.
So I have questions for Dr. Brooks as well as Dr. Diehn. So Dr. Brooks, in 2012, there was news of a young inventor, Jack Andraga, who developed a paper and carbon nanotube-based test that was about 2 orders of magnitude more sensitive in detecting prostate cancer antigens. So presumably, since PSA detection is via ELISA, I was wondering if you've heard of this guy and whether PSA detection, I mean, the big hesitation of people to get the regular biopsy screenings is because it is invasive, as you mentioned, and there's quite a bit of blood that is taken out. I was wondering if you've heard of this guy and whether there's any technology that is aimed towards improving PSA detection efficiency.
So this is the ultra-sensitive PSA test that goes down several orders of magnitude lower to detect PSA. Yeah, I know, but I think he was at University of Pennsylvania. I'm not sure. Oh, okay. Oh yeah, that I remember that also. Yes, so there are several people who've worked very hard on developing very sensitive tests for PSA. Now, in contrast to circulating tumor DNA, the problem with PSA is not one of sensitivity, okay? Every man has some measurable PSA in their bloodstream, including you. And that's just because PSA is a protein that comes from the prostate, okay? So the issue in prostate cancer is not whether or not we can detect it at very low levels. It's that since everyone has it and cancer elevates it, but so does enlargement of the prostate, infections, and so on, it's a problem of specificity, that this elevated test doesn't necessarily mean you have cancer. Now, the use potentially for ultrasensitive forms of PSA detection is after I take out a man's prostate, his PSA should go to 0. So maybe in that man, if I can measure an ultrasensitive PSA, I'll get an idea of which man recurs earlier. We've had these tests around for a while. It doesn't necessarily change what we do clinically, so I don't know that that's going to be a big win. Question? So one of the issues with prostate cancer has been that we can't see it. When we do ultrasounds, in the olden days we thought we could see stuff, but realistically nowadays There's all kinds of artifacts in the prostate that make it so, because you get funny growths in there and stuff like that, you can't really pick out what's cancer versus what's not cancer. So the strategy that was developed here at Stanford in the late 1980s is that since we can't see it, what we'll do is just cover all the geography. So we'll get biopsies at the top, middle, and bottom portion of the prostate on both sides to diagnose cancer. In the last few years, there's a couple new approaches in MR technology that's called, multiparametric MRI, which basically are different sequences that they've developed that look at, probably the best one is what's called diffusion-weighted imaging that looks like the mobility of protons within parts of the prostate. And the mobility is restricted in areas where there's cancer. So it lights up based on the way they tune it with their Fourier transformation, which I have no clue what that is. But it's the way they tune this image so it lights up like a light bulb in certain prostate cancers. So, but it doesn't do it in all prostate cancers. So this gets at a different issue in testing. Recall last time I said the problem with PSA is specificity. The problem here is a different problem. It's called sensitivity. Some prostate cancers light up on MR imaging, but not all of them. And that means you're going to miss some, and you might miss some of the aggressive ones. So, but even still, if you can light it up on the MRI, we have technologies now where we can actually fuse ultrasound in real time with the MR image in real time. So you get an MRI scan, you put it on, you do the ultrasound, and in real time, the MR image is right there, so you can put a needle right into it. So we've just started doing that this calendar year.
Question?
So I have a general question about going to market. So it's great to hear about all the things that are going on in the labs, but what is the process and how long does it take for things to get out?
That's a great question and a complicated question because it, of course, very much depends on exactly the approach. Taking a new cancer biomarker to market has been challenging. The main issue is that in order to be available through a company, which is what patients would want so that anyone can get it, to really make that viable, there needs to be insurance coverage of that ultimately, because the insurance has to agree to pay for it, of course, so that that can be reimbursed. And that requires many, many studies to prove, and this is a good thing, of course, because you don't want to pay for things that are not helpful, but you need to do a number of large clinical trials to really try to prove that a technology helps. Either it helps save more lives or it helps save costs. Usually those are the two things people try to show in the healthcare system. And so those, it generally would take years to get really, and we're talking numbers of years, 4-ish, 5-ish years would be pretty decently fast to get it out into general use. Now, you can have a company that could start a technology where patients could private pay, of course, and that often is how these things start. But there's a lot of clinical trials that have to be done, and that takes time and takes a lot of samples.
Yeah, just to follow up on that, I'm part of a research group called the Early Detection Research Network at the National Cancer Institute. And the time from discovery of a biomarker until it's in the market is equivalent to the amount of time it takes from discovery of a drug to getting it into market. And that's about 15 to 20 years. There are a few that, so there's one in prostate cancer that it ends up, it's about 5 or 6 years from discovery until the time it gets to market. But that's the fastest I've ever seen. Yep.
Thank you very much. Please join me in thanking Dr. Brooks and Dr. Diehn.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.